Hi, I'm Dr. Sean Dowdy, Chair of the Division of Gynecologic Oncology at Mayo Clinic in Rochester, Minnesota. In this short video, I'll review a number of strategies we've implemented to improve recovery after gynecologic surgery. This concept is referred to as enhanced recovery after surgery, sometimes abbreviated ERAS, and previously referred to as fast-track surgery. Some of these interventions are the responsibility of your provider, while others are a joint responsibility between your provider and you. So I'll review not only what we do to improve recovery, I'll cover what you can do to get back into your usual activities most quickly. And that does not have to include being admitted to the hospital. There are many things we do to enhance recovery, but I think it's easiest to divide them into three categories. These include optimizing nutrition, achieving excellent pain control, and while minimizing the use of opioids and maintaining normal fluid balance. The first, optimizing nutrition, is the easiest. This is important because nutritional status directly impacts your ability to heal, which improves recovery. Think of surgery like a marathon. Surgery subjects your body to stress, and the best way to handle that stress is to be prepared for surgery, just as one would prepare for an athletic competition. We want you well rested, well hydrated, and loaded with carbohydrates so that you have the energy stores you need to heal. For this reason, we recommend eating and drinking normally the day before your operation. Undergoing anesthesia with a full stomach can be problematic, so we don't want you to eat anything solid after midnight, but we do want you to be appropriately hydrated. For that reason, we encourage you to continue drinking clear liquids until you leave for the hospital the morning of surgery. Also, since you won't have a morning meal, it's helpful to drink 16 ounces of your favorite fruit juice before you report to the hospital to provide a store of carbohydrates. After surgery, you may feel nauseated from the anesthetic agents or the surgery itself. If so, you may want to avoid eating or drinking, but if that nausea passes, you should feel free to eat and drink whatever sounds good to you. Your provider will prescribe medications to reduce nausea and vomiting, as well as medications to prevent constipation and encourage your digestive system to return to normal function. Patients with diabetes or other conditions may have limits placed on their diet, but in general, if you're thirsty, drink, and if you're hungry, eat whatever sounds good to you, not what sounds good to those around you. Start with small meals or even just a few bites at first to make sure it agrees with you. Nutrition after surgery can also be aided by drinking energy-rich supplements such as Ensure or Boost, and we'll encourage you to try these. Again, we want your energy stores maximized to maximize healing. But don't force it. 10 to 20% of patients will develop a short-term condition called after abdominal surgery called adynamic ileus, in which the bowels don't move through the intestines normally. If that occurs, we may need to discontinue food and drink for a time until it resolves, but avoiding nutrition after surgery will not reduce the chance of this happening. But remember, some degree of nausea or even vomiting, small amounts, can be normal at first after surgery, so don't be discouraged. The second concept, excellent pain control, is one that creates anxiety for many patients having surgery, especially if it's the first time they've had surgery. Will you have pain after surgery? Most patients will have some degree of pain, but if our goal is to completely eliminate pain, you'd be asleep for several days, and none of us want that, even if it didn't have the potential to create other complications. Rather, our goal is to control your pain so that you're comfortable enough to resume activities such as getting out of bed and walking around the hospital. To encourage walking and also to minimize the risk of infection, urinary catheters are removed the night of surgery, although it may need to be used longer if you've had surgery on your bladder. Most patients will walk the evening of surgery and are able to resume most normal activities after a week or two, and strong pain medications are often not needed after a few days to a week. In fact, most patients are pleasantly surprised how little pain they have. How do we accomplish this? It starts from the moment you're anesthetized. We take great care to position you safely, provide pain medications prior to incision, use the smallest incision possible, and when the procedure is completed, we inject incisions with a local anesthetic agent. For larger incisions, we use a long-acting agent that is effective for up to 2 to 3 days, at which point pain for most people is significantly improved or resolved. But a local injection is often not enough, and so oral pain medications like acetaminophen or Tylenol and ibuprofen or Advil will be the first medications given. Often we also use an injectable derivative of ibuprofen called ketorolac, which is extremely effective for post-surgical pain. Since some of these medications are available over the counter, you may not think they'll be useful, but in fact, they're extremely effective, and we recommend taking them throughout the day for the first few days or week after surgery, even if you're not having pain. Opioids are only given if you're still having pain. It's important to point out that both acetaminophen and ibuprofen potentiate or improve the effectiveness of opioids when given around the same time. So by using incisional injection of local anesthetics and acetaminophen and ibuprofen, patients require much lower amounts of opioids after surgery, and many require none. In fact, even after major surgeries for advanced cancer, nearly half of patients stop using opioids after 48 hours, and most patients only need a few pills at home. Don't misunderstand me, it's critically important to us that your pain is well controlled, but we want to control it with the smallest dose of opioid possible. This is important because of the side effects of opioids like nausea, constipation, and skin rash, but also because about 6% of patients will become dependent on opioids after surgery. The lower the amount you use, the lower chance you have of becoming dependent. Since starting enhanced recovery in 2011, our patients have used 90% less opioids in the first 48 hours after surgery, yet still have excellent pain control. In fact, we estimate that we've saved roughly 40,000 pain pills just in the first 48 hours after surgery since we started enhanced recovery. Good pain control will also allow you to be physically active earlier and will get you back into your usual routine faster, which will also prevent complications such as blood clots. Remember that all patients are different, and an occasional patient may need opioids intravenously rather than orally, with about 2% needing patient-controlled analgesia for the IV opioids. Patients with pain who have used opioids prior to surgery have a higher chance of needing more opioids to control their pain after surgery. For that reason, if you've used opioids in the 30 days prior to surgery, be sure and alert your provider. We've been able to achieve this level of pain control with only occasional use of epidurals, which may interfere with your ability to walk after surgery and are rarely associated with serious complications, and may reduce blood pressure, which can interfere with our next topic. The last topic is maintaining normal fluid balance. Dehydration can present challenges during surgery by decreasing blood pressure, and if severe, may even damage organs such as the kidneys. This is the reason we allow patients to drink clear liquids up until they leave for the hospital. It's also the reason that we've not used bowel preparation for nearly 8 years in our practice. Bowel preparation results in diarrhea with accompanying loss of fluid and electrolytes and interferes with sleep before surgery. Not to mention, patients hate bowel preparation, so why should we use it if it's not beneficial for patients? Although there has been some concern about a higher risk of infection without bowel preparation, in our practice, we have taken other steps to reduce infection rates by 80% over the last several years, even without bowel preparation, so that we have among the lowest rates of infection in the country. But while dehydration can be damaging, overhydration can be equally problematic. While it's very difficult for a patient to become overhydrated by drinking oral fluids, this is common if intravenous fluids are not properly managed. Just like Goldilocks, who didn't like her porridge too hot or too cold, we want your fluid balance to be just right. During surgery, we'll give you enough fluids to maintain normal pressure and blood flow to your kidneys, but not enough fluid to cause swelling in your legs, hands, face, or lungs, which can cause a serious condition such as pulmonary edema. Furthermore, intravenous fluids contain a huge amount of sodium. In fact, 1 liter of normal saline has about as much sodium as 50 bags of potato chips. So if you receive 10 liters of fluids, not uncommon before we initiated enhanced recovery, that's equivalent to the salt load of 500 bags of potato chips. How do you think your legs would feel if you ate 500 bags of potato chips? For that reason, fluids will be administered at a low rate the evening after surgery, and in most cases discontinued the next morning to encourage you to drink liquids by mouth. While we can give fluids and calories through your IV if needed, by mouth is always the safest and most effective route. Once you're able to eat and drink with minimal nausea, walk without assistance, have good pain control on oral medications, and we're not concerned about a potential complication, it's safe for you to leave the hospital. Hospitals are for patients who are ill, and if you can do all the above, congratulations, you're not ill, and the hospital is not the place for you. Many patients may elect to stay at a hotel in town for an additional evening for reassurance, especially if they have a long drive home. But it's safe to drive or fly home the day of discharge if you desire. If you feel your provider is not following what I've outlined, ask them why. There are likely to be very good reasons why you're being treated differently based on your medical conditions or the specific operation you had, but close to 100% of our patients are managed as I've outlined. I hope this short video communicates a few of the many things we do to make your recovery as short as possible with the best surgical outcome, and is also informative of what you can do to hasten your own recovery.